In fact, so many people to thank before I even start. I think we all of us have to be thankful to the science, clinical research, translational and transmissional efforts that have gone on to transform ourselves into better clinicians. In fact, we depend upon the patient's trust and patient's family's trust in us to transform ourselves. For that prescription that we want to order, in the back of our mind, I'm sure, the trust that patients have reposed in us will definitely come into the play. In fact, I was thinking that we may not be able to find such a large audience in the beginning of the meeting, so we'll have some kind of a chit-chat. We as old hacks keep on discussing what is wrong, what is right, what is good, what is bad, what is deteriorating, what is improving. While science doesn't wait for us, science keeps on moving on. It is so dynamic, so kind of engaging to an ordinary clinician like me. Hence, I thought we'll have some kind of a chit-chatting session on this particular topic called trust. Does the trust, can we go on to the first slide, please, on that? Yeah, go back a little. Yeah. Go to the next slide. Hence, even during Osler's time, friends, make note how Osler, yeah, okay. Even during Osler's time, he wanted us to visit understanding of changing practices for rejuvenation, renovation, and rehabilitation, like me, who is older, and younger to become better. Reintegration with the peers in our community, that we don't want to be left behind. And also resuscitation before the ink of the signature of the registrar who has given us the permission to practice medicine falls off from our certificate, and when the patients examine our certificates, he gets worried that is he being treated by an oldish guy like me. A prudent question is half of wisdom. That is what is called translation. I'm sure plenty of examples exist in the literature wherein we have been told that it is this led to the clinical science, clinical research, publication, appearing in guidelines, affecting the transformation of our practices. This particular cartoon is very, very important. While somebody wants to give you a wheel which is roundish and which can easily move on our lives of medicine practice and in general, our own lives, we want to struggle with the squarish wheels, trying to push ourselves, and sometimes we may be laughing stock in front of our own peers and the organizations which support us very diligently, very continuously, very, very powerfully. In fact, this transformation is one, as you go out of this meeting hall, that you remember what you have learned. In fact, many of us tend to forget to update, as we call it in the modern times, as to what is the copy of this particular program that I will be updating myself in the frontal cortex, in a lighter vein. Just because I don't transform, it doesn't mean that I'm archaic. My clinical wisdom will dictate. Hence, we have something like a 500-year experience of clinical wisdom on this stage in the next about half a minute. It will be led by my mentor, my colleague, my friend, Dr. Iyengar, to come onto the stage. And he is one of the very respected figures in India and also internationally. May I request followed him by Dr. S.S. Ramesh, please. Also Professor C.B. Patil, please. Professor Ravindranath, please. My young friend, Dr. Prabhakar, who has been to some extent, my alter ego, because I think of what I want to do, but he would have already thought about it. And we would have loved to have Dr. C.N. Manjunath, Professor C.N. Manjunath, who is currently on an assignment in Delhi, as you all know, as a Member of Parliament of India. Kudos to him. And give him a big hand, please. May we kind of convey our greetings and best wishes to him for doing his human service to the organization where he worked for diligently, and also for the public, and able to influence the society and also the governments of his times in a very, very assiduous manner. Anybody else is left out here? Manjunath? Okay. Now, it is also my proud privilege to invite Dr. Iyengar also onto the dais, who is again one of the senior most professors of our country and also of our Karnataka state, to join. And also Professor T.R. Raghu, please come, sir. Some of the questions that we will be discussing, or topics that we are discussing, these are all kind of a very very mundane topic. All clinicians have this term called Weltanschauung. It only means that I have my opinion, come what may. All of us have worldview of medicine and in life in general. Remember this word, and it will be interesting to listen to the opinions of our own colleagues on the dais here. In fact, this important concept of people culminating to have cardiovascular disorders and death starts off with the risk factors. Zhou and his colleagues should be congratulated for perceiving this particular concept, and nearly dozens of times I must have used, and so also the people on the audience here, suggesting that the kind of niche to develop cardiovascular disease is seen nearly 30 to 40 years before the cardiovascular elements develop, resulting in morbidity and mortality. So trust. Session 1, medical practice. And you already have them on this dais here. Trust is the glue of life. So also Stephen Covey said. You may be interested to know about him as we go along. Trust but verify. Do the patients and their families worry about it? As Ronald Reagan, long time ago, said that. So the points for discussion could be, quickly, what is trust? Let's start off with the right-hand side, left-hand side of mine. Dr. Raghu can say what exactly means by trust to him when he talks about trust by the patient, or you can use the mic, sir.
Thank you, sir. See, trust is one thing. Probably any patient comes to you or any person comes to you, you should listen to him at least 5 to 10 minutes, whatever he says. Then you tell what you want to tell. Probably then you get the trust of the patient. He has got some agony, something in his mind, something in his problems probably, but you want to express. Now what is happening is there's a trust deficit, means you don't have time to listen to the person who has come to you. You want to see in 5 to 10 minutes, probably send them home, get some investigation. That is a trust deficit. Probably you should listen to them. Probably most of the time you can make a diagnosis with the history.
Okay, fine. Okay, now let's so individual's role, doctor, patient, vis-a-vis family. How about Dr. Prabhakar? What is it he has to say about doctor first?
As rightly pointed by Dr. Raghu, it all starts with listening and empathy. Today's world, we are lacking trust because we are more worried about what we want to tell as a doctor. I know what is the best for the patient very quickly because patients come with lots of information ahead. We don't discuss. So the individual role of a doctor is to listen and try and understand what the patient is seeking from us rather than trying to impose what I know and what I want to do for the patient.
How about family, Dr. Patil? What is your perception of a patient looking for in you and as in a doctor?
I think in the management of the patient, the family is very, very important. Apart from unless whatever he is revealing to us, sometimes they may be involving with a complex disease or a complex diagnosis, what we are making, and maybe a chronic illness or maybe related to the genetic problems or whatever it is. So at that time, the family becomes very important, especially taking the family into the faith for our routine management, as well as in continuation of the whatever problems he is suffering from, and what best we can do there. Thank you.
Wonderful. In fact, the patient and the family both should be treated, not just the patient alone, I guess.
Yeah.
That's what you want to convey.
Yeah.
May I switch on to Dr. Ravindranath, please? He has stepped into big shoes of Dr. C.N. Manjunath as the professor and director of cardiology at Sri Jayadeva Institute of Cardiovascular Research. And he has been doing an admirable job, I'm sure. When it comes to patient and the family, he'll be kind of as an administrator who controls a large group of professionals of nearly 100. He might have some insights into this. What exactly he comes across as the director when he's dealing with thousands of patients and hundreds of professionals. What is your take on that, sir?
Yeah, I agree. First, patient, we should, most of the times we try to treat based on the investigations. So we should not treat the disease. You should treat the patient who has a disease. That means we have to look into the overall socio-economic background. And now that's how the concept of team approach. Involve the patient, involve the family, involve the other specialties. That's our team concept has come. And also look at the socio-economic background of the patient before we take any decision. And now these days people are going, I come across a lot of patients coming with second opinion, or sometimes third opinion. That means there is somewhere lack of trust, some sort of trust has been lost. So that's why the concept of family physician, the person who goes first. So now whatever opinion is given by the first doctor, some people, they carry it away. Now in spite of coming to us, that opinion is different. So they don't change their mind. What is going into their mind? First opinion. So you should be more responsible to give the opinion when we see the patient. And also, we should ideally we should go by if the patient is realized that we are by your experience and it is more of ethical and more of evidence based, then they develop more trust because they Google. They know the people, they
Thank
come
you
with
so
all
much.
the
Yes,
information.
you pointed out.
So those things we should take into considerations.
Yeah, trust issues, if they come out of Google, let's listen to a very kind of senior and experienced person like Professor Iyengar. What is his take on team care and trust issues? Because he led an admirable team at St. John's and also a very kind of a rather, can't say very large team, small teams of professionals in Manipal Hospital also and counseling them. What is his take on this team care and trust issues?
Yeah, firstly, good morning to everyone. And sitting here, I feel we are facing a tough Viva Voce with Dr. Nagaraj Desai. Anyway, coming back to just a few words about definition before I go to the trust, for example, child has, unequivocal, unambiguous trust in mother and father. And usually wife has trust in husband, husband has trust in wife. If this trust breaks down, of course, it results in divorce. Now here, when patient comes to doctor, his trust, does it mean satisfaction? No, it is not satisfaction. Because satisfaction depends on your previous experience. You are satisfied with his treatment or dealing or not. Trust is something, it is your feature vulnerability. Vulnerability dependence on the doctor. So you have to decide whether you are ready to commit to be vulnerable to your future. So it is a future sort of futuristic perspective. Now coming to the team, you mentioned, other thing before I go, I think he mentioned for the second opinion, sometimes it means
We'll
lack
come
of
about
trust.
second opinion a little later.
Yeah.
Only team care, you
Team-
order the
team care, of
angiogram,
course.
your associate does this angiogram,
Yeah.
and patient has some issues. Do you have concerns about it, or how do you want to
Yes,
tackle
team
that?
Care, team care is, as Dr. Ravindranath mentioned, you should try to involve your own team when you have doubts, or when you think the patient has some doubts. You could always consult your colleagues. It could be, if you are a cardiologist, you want to refer to an endocrinologist, a neurologist should not hesitate in doing so. And that's what basically team care means. I think you should involve your team to see that patient feels comfortable.
Okay, now let's listen to Dr. Ramesh. What is his take on this team care and trust issues? Does he have any difficulty in convincing the patient and somebody else does the angiogram or angioplasty and the patient family and comes out and they start discussing what exactly he feels about it?
Yeah, I think the way we practice medicine has changed.
Brief.
I just quote a few. Trust is a very complex issue. I still remember when I was in probably second MBBS, third MBBS, one of my teachers, the principal actually said, doctors, the patient and doctor relationship and how much patient trust. For example, he said, a lady who gets married, the first night she hesitates to disrobe. But the same lady next day morning, coming to a doctor, she has no hesitation in disrobing and lying down. That is the trust that patient has on the person.
Wonderful.
But when I finished my DM, when I asked my teacher what is his advice, because I'm going to start practice, I was shocked because he said, look, patient is your patient as long as he sits in your consulting room. Moment he leaves, he is no more your patient. Don't expect too much from the patient. You're only a consultant. I was shocked. I really couldn't believe that, I can do that. And but over the time, I have realized, yes, that's I think one of the best advices I got. Because the patient and the doctor's relation has totally changed now. Earlier, patient used to just come trusting the doctor. Many times I have seen that they won't even ask questions. They just say, okay, whatever it is, you just see.
We listen
But
to you.
today, patient, family, friends, they have 100 questions. Many of them even talk as if they don't trust you at all. Actually, you wonder, why did they come to you? There are many issues. Partly, I think, doctors driven. Partly, it is patient. And I think the major culprit is social media.
Okay. Now, yeah. Can you wind it up finally?
Yeah. Now, another factor that has changed in patient care is it is no more individualist. Earlier, when you start practice, one-to-one, we could talk to the patient. But today, in institutional practice, we have a team care. So the entire team has to have the same view.
Yes.
That is another problem because each one, like I have some say, but my assistant goes and says something else. My resident says something else. This also causes a lot of confusion, and that is how some lack of trust. I think that's where we have to work on.
So the communication within the team also has to be perfect in case you are part of the team. Thank you so much for that particular point. Can we go on to Dr. Suresh Yavagal, please? In fact, Professor Yavagal also led a large team. He was also with Sri Jayadeva, and now he has his own practice. And also, he must have had a rich experience when he played that institutional role. According to him, what should be the modern role of institution when he is practicing medicine?
Dear friends, institution has got an important role. The patient must first believe in the institution. When a case comes to Jayadeva, he comes with all the faith. They come to the institute. So there itself they get 50% of the relief. Actually, in any disease, if you take, there is an organic factor, there is a psychosomatic factor. Organic factor, the doctors are dealing with. Psychosomatic factor, so many factors are involved. Doctor's role is also there. I will give you an example. For example, people go to Hyderabad and swallow a small fish and they get relief from asthma. Why? Because they believe in that. So the psychosomatic factor is addressed. Not that they will get full relief, but the psychosomatic factor is relieved. So to that extent they get. Similarly, people go to Ballari and drink overnight. They keep water against the moon and they drink in the morning in the copper vessel and they feel they get relief because they believed in that institution. So institution has got an important role. Whoever comes, if they see that the patient is satisfied with their whatever they come with, maybe it is the treatment is one aspect. Other things, psychological also, you have to discuss with the patient so that their problems, their solutions, if you sort it out, then it will go a long way in the management of the patient.
Thank you so much, sir. In fact, that's a wonderful suggestion that institution plays an important role in modulating, if I could use the word, or kind of niching your career in the future years. So if you are part of an institution, be part of the institution fully and be a Roman when you are in Rome. That could be a reasonable approach. Let's get back to Dr. Prabhakar Koregol because he does a lot of emergencies. And I want to know from him, when compared to the trust issues versus the emergency care, does he have, because in the night he was going at about 9 o'clock to do an PCI, I want to check with him, does he have any trust issues cropping up when he does these emergency procedures?
The maximum trust issues come in the emergency care rather than in the chronic care because patient doesn't have too much of an option. We service in the chronic care as Prof suggested, they can go for the second, third, fourth opinion. And this is where the maximum bad events can also happen. So those two together makes a trust issue very, very difficult. But fortunately in a tertiary care systems where I work, when somebody I have lots of good friends sitting here who says, Dr. Prabhakar is the good cardiologist, you go take care of him. That one sentence has much more impact than the institute, the individual, my degrees, my experience.
Okay.
That's how
So the physician who kind of sends across the patients could also play a crucial role. In other words, you need to have some kind of a network of well-wishers. Maybe this cardiology academy would play some role in connecting one another to communicate with each other or one another. Now, Dr. Patil practices chronic care more than acute care. In a one sentence, could you tell me what exactly plays in a particular patient who come to you every year for 10 years, 20 years, and 30 years? Is it because you're less expensive? Or is it because there is a trust issue?
I think because they have got a chronic illness, I think we need more faith in continuing our medical care. Along with the medical care, expertise, and sometimes we may have to involve many other specialities in treating him, and all these are very important in getting, along with the family's confidence and family's cooperation in dealing with all these people.
Thank you so much, sir. Indeed, family's involvement and enrollment in the chronic care plays an important role in formulating it. I'm sure Jayadeva has expanded across Karnataka. Wherever Jayadeva goes, there is a problem there for others. Hence, it is important to know, in case he has a practice setting in Mysore, in Gulbarga, in Hubli versus Bangalore, does he have any problems in setting up the care there? Recruiting the HR, recruiting the patients, or recruiting the technology and acceptance of the technology by the patients?
So many questions.
In one sentence.
So many questions are unexpected. I did not face such an examination in the DM cardiology, so which are all new. We have to think and answer. That is real. That is what in practice you have to confront with all those.
No, not at all. Just in a lighter vein, many of us do not think like this. I thought I'll put to the forum for you to kind of briefly advise as to what could be our stressors. If I want to move from Bangalore to Gulbarga, would you advise? Or will there be difficulty in recruiting a Bangalore DM into Gulbarga city?
Now actually it becomes more of a regional. They come to us. So we have some colleagues, not necessarily related to your own institute, some institution elsewhere. So the practice pattern is patient should be having a less problem in commuting and so many times they come from Raichur. I have seen a patient. So I don't worry, our colleague is there, nothing much we can do.
So the team care and the enrollment of the colleagues
we can talk to them and
will definitely be helpful.
That's how it, so we
that
always
is important.
Pass on the message. So we unnecessarily have the trouble unless we are doing something different. So take care and be on follow-up. And follow-up, once the patient stabilizes, they keep coming again, apprehension, reassurance and counseling. So we make the frequency of visits can be reduced to, instead of 1 month, you come after 3 months, 6 months. Anything is there now, we have digital and we can always contact over phone. We can definitely reduce the intervals of patients.
So the rural, semi-urbans, urban,
we can
and the practices, you will have to tailor your approach to the practice of medicine in general and cardiology in particular. In fact, risk-taking behavior when you do something new for the particular patient, I know Dr. S.S. Ramesh since 40 years and plus. I think he should be commenting on this. I'm skipping Dr. Iyengar simply because he is elder to me. I cannot ask such, silly question.
No, I just did not understand this. You're just taking behavior by the patient or by the doctor?
About 25, yes, that's important. 25 years ago or 30 years ago, when you advise angioplasty for the first time without stent, without drug-eluting stent, and with the minimal surgical backup, where the procedures were not always without any dangers, including death of the patient on the table. How did you manage that patient?
Yeah, I mean, of course, it's not limited to cardiology.
Yes, that's right.
Let me, of course, as I said, practice has changed. We do do more complex cases now. Even as a physician, I'm sure the patient, probably the disease as well as patient behavior is also complex. So, basic problem, I mean, whether you're
at this stage, when you do the POBAR to a patient of a vessel, will you be worried about it or will you not be worried about it?
I'm saying, whether it is acute care or chronic care, basically, especially when you are taking a risk-taking procedure, communication is the most important.
Yes.
I think if you are able to communicate to the patient, I just have to tell you why, especially when you asked about institutional care, there was a survey conducted by University of Chicago. And, public said, 64% of the public said that they trust individuals, doctors, rather than institution. Interesting.
Converse.
Of course, that has changed now, at least in India, gradually trusting institution. And then they say the problem with doctors, the trust issues, and that is where I want to highlight. 25% of the patients said that they don't trust doctors because they spend very little time with them.
Sure.
14% they say they do not know me at all, they don't try to understand me. And 14% say they do not take, listen to me at all. Patient will be talking, but you are not interested to listen to his story.
Look at the computer.
And 10% do not give this is the basically problem, information. Many times we feel we know everything and just do as I say. But today with Google and various media, patient has access to information and he wants answers to that, and I think that is where the problem comes. If you are not able to communicate properly, and especially when you ask about rural and urban, another problem in India, which will not be a problem in outside, is our language.
Sure.
With hundreds of dialects and languages, unless you are good in communication, it's going to be a problem.
Sure. Okay, let's listen to Dr. Yavagal. In second opinion, we did discuss partly when we were discussing. Can you make one couple of sentences statement about the taking a second opinion? Is it a lack of trust?
Second opinion, when we take, the person whom we have referred the case should always remember they should not comment on the previous person's prescription. They should tell, they can tell whatever they have done is good, but still I like to modify like this. Instead of telling, if you tell what they have prescribed is wrong, it creates a bad impression, the trust will go off. So, second opinion, the persons who receive any patients for the second opinion, they must remember that the first person is also his colleague, and whatever best with his knowledge he has done it. And second person who is giving the opinion, I told you, he can modify the treatment, there is no problem. But in a very nice way he can tell, whatever the first person has prescribed is very correct, but you are not getting relief, so I like to modify like this. Patient will not get bad impression about the first person. That is very, very important.
Yeah, thank you so much, sir. In fact, all the faculty on the stage have done a wonderful job. In fact, we could have gone on with this, and Dr. Ravindranath has a parting counsel for all of us. He has his,
Regarding a second opinion.
Yes.
So not only going elsewhere and patients not believing, not having trust, taking opinion with other doctors. In the same institutions, in the same institute, I will ask other colleague who is experienced, or even my junior or associate, I will tell them, so have a look at it. When we are fixed between the 50, should not have the ego. The patient should be our target and priority. I keep asking sometimes even our colleagues.
Sure.
That should
wonderfully
be
put it, sir. In fact, we are very thankful to all the panelists here who have gathered on the dais. In fact, the professor who lived nearly 100 years ago and died nearly 100 years ago, he did mention about the philosophy of the age have become the absurdity of the next, and the foolishness of yesterday has become the wisdom of tomorrow. When you are listening to this particular panel, you would have appreciated that quite a few of us do think and get archaic with the changing times. In other words, having this statement will be very useful as you go along, learn about science, clinical practice, and emerging possibilities.